Chronic subdural hematoma, or CSDH, is an abnormal, steady accumulation of blood and fluid between the brain's surface and the dura mater. The prevalence of this condition is rising, driven largely by an aging population. Elderly patients and those on chronic anticoagulation therapies are especially vulnerable due to frequent minor falls. This head CT scan shows a massive preoperative chronic subdural hematoma exerting significant mechanical force on the underlying tissue. For decades, the standard of care for a collection of this size has been surgical evacuation. Surgeons typically relieve this mass effect through a burr-hole, a small opening drilled into the skull, or a decompressive craniectomy, where a section of bone is temporarily removed. Looking at this postoperative scan, we see the immediate success of the surgical evacuation. The fluid collection has been largely reabsorbed, and the midline shift has resolved, leaving only a small hemorrhage at the drain site. Yet, despite these structurally successful initial evacuations, long-term outcomes reveal a persistent problem. Recurrence rates average 11% or more in most surgical series, meaning a substantial number of patients require repeat invasive interventions. This follow-up CT scan demonstrates what that failure looks like radiologically. 72 hours after the intervention, we observe frontal pneumocephalus, trapped air within the cranial cavity, alongside a persistent subdural collection and fresh hemorrhage. If the fluid is completely drained during surgery, why does the hematoma consistently rebuild itself? Surgical evacuation only treats the physical symptom, the accumulated fluid. It ignores the underlying biological engine driving the disease. The classical medical teaching explains CSDHs as liquefied acute hematomas. The theory is that traumatic sharing of bridging veins in the subarachnoid space creates an acute bleed that slowly aggrades into a chronic collection. This schematic diagram illustrates the legacy model, showing blue bridging veins traversing the dura. But the biomechanics of this model fail under scrutiny. These veins are 1 to 3 millimeters thick. Selectively rupturing them into an exceptionally thin inner dural layer requires massive force. This physical reality contradicts the clinical histories we observe. Many patients presenting with a chronic subdural hematoma have no history of traumatic brain injury. The legacy theory also fails on a temporal level. A slow venous hemorrhage causes symptomatic fluid accumulation within a matter of days. However, CSDH symptoms typically take 4 to 7 weeks to manifest after an inciting event. The modern hypothesis views CSDH as a chronically active disease process, rather than a passive, deteriorating acute bleed. The biomechanical properties of the dural layer and the prolonged clinical timeline prove we are dealing with an active pathology. Treating that pathology requires a physiological arterial intervention. To understand this active process, we must shift our anatomical focus away from the subarachnoid veins and look directly at the dural border cell layer. A minor dural injury triggers a persistent inflammatory cascade fed by the middle meningeal artery. Inflammatory cells activate procollagen, forming a fragile neomembrane. Ongoing inflammation releases angiogenic factors, inducing erratic, fragile neocapillaries to grow within this newly formed membrane. Because these neocapillaries are structurally unsound, they constantly leak blood and fluid exudate. This continuous internal bleeding drives the symptomatic expansion of the hematoma cavity. The biological engine of the disease is a pathological dural capillary plexus. Since this entire network is fed by the middle meningeal artery, devascularizing that specific artery should halt the disease progression. This identification of CSDH as an active neovascular inflammatory disease shifts the clinical focus. The artery itself becomes the primary therapeutic target, not the fluid cavity it produces. If the middle meningeal artery is driving the disease, the vascular architecture will reflect it. The MMA should structurally adapt to meet the increased demand of the growing hematoma. This diagnostic angiogram, a medical imaging technique used to visualize the inside of blood vessels, confirms this adaptation. The white arrow points to significant pathological hypertrophy of the MMA on the same side as the lesion, is larger in caliber than the opposite side, accommodating the engorged artery. While an increased arterial caliber implies involvement, we require proof of active membrane involvement. We achieve this using supraselective digital subtraction angiography, a technique that digitally removes bone and tissue from the image to cleanly isolate blood flow. During a selective MMA injection, these DSA panels reveal a pathological contrast blush. This enhancement perfectly aligns with the hematoma membranes seen on the CT scan, providing visual proof of dural hyperemia and ongoing microhemorrhages. Clinical data reinforces the artery's central role. Research demonstrates that an MMA diameter smaller than 1.5 millimeters is independently associated with procedural failure. The visual evidence of structural hypertrophy, combined with the active contrast blush on angiography, shows that the middle meningeal artery is the vascular engine maintaining the CSDH. Because the middle meningeal artery acts as the supply line for the hematoma, selective embolization is the definitive method to interrupt the inflammatory cascade. However, the procedure carries rigorous constraints. The MMA shares dangerous anastomotic connections, natural communication pathways, with the vascular network supplying cranial nerves and the eye. This schematic maps high-risk collateral pathways branching off the MMA near the foramen spinosum. The petrous branch supplies the facial nerve, while the cavernous branch connects to the internal carotid artery. Further up lies the devastating meningo-ophthalmic variant, where the MMA supplies the eye. This lateral DSA image shows how these variants appear in practice. The white arrow traces a recurrent middle meningeal artery, originating directly from the ophthalmic artery, marked by the black arrow. Unintended occlusion of these collaterals causes severe ophthalmic or neurological complications. Safe execution requires precise microcatheter navigation and rigorous superselective mapping to starve the CSDH without compromising vision or cranial nerves. To bypass those hazardous proximal skull-base collaterals, the interventionist must navigate the microcatheter distally, positioning it securely into the frontal and parietal branches of the MMA. Once optimal distal positioning is confirmed, the deployment phase begins. The interventionist injects a liquid embolic agent, such as EVOH, a polymer compound that solidifies upon contact with blood to create a permanent vascular cast. These post-procedural scans show the radiologic result. The liquid agent completely conforms to the arterial tree, hardening into an opaque cast. This solid cast permanently severs the supply line to the pathological capillary bed, starving the inflammatory membranes and allowing natural resorption. By casting the distal branches, the endovascular approach permanently de-energizes the inflammatory cascade, halting the disease at its source. Middle meningeal artery embolization changes the long-term disease trajectory, proving effective as a primary standalone therapy or as a rescue adjunct following surgery. This CT shows surgical failure, a massive residual collection. After MMA embolization, we track the reduction. At 1 and 3 months, scans show consistent thinning of the hematoma. By 6 months, the scan demonstrates complete radiologic resolution, with the brain fully re-expanded. By deactivating the underlying dural pathology, MMA embolization ends the cycle of recurrence and provides a physiological solution to chronic subdural hematoma management.